So today's talk is controversies to consensus. I like to highlight some important points and take home messages. As you know that hypertension, just now we heard Dr. Simon talking about the hypertension as one of the risk factors for osteoarthritis and obesity. We have a really good, important prevalence of this hypertension in India is too much, but it is not being aware of it, almost nearing 29%. Of course, the prevalence is high, at the same time awareness is also low, and proportion of hypertensives under BP control is also low. So this is 1733, Dr. Hales is the first one to measure blood pressure. He cannulated the carotid artery in a horse with a brass pipe like this and tried to measure the blood pressure way back in 1733. Now coming to the Indian guidelines, we have some guidelines which I like to discuss. We all know how to record the blood pressure. This is too fundamental. Let me go for that. Of course, the measurement of blood pressure is not confined only to the way which we are following it, because you know that there will be a lot of intra-observer, inter-observer variations, and it also depends on the patient condition as well as the BP apparatus. Also, many of the BP apparatus may be faulty also. Therefore, we have a specific group of patients who will get benefit from a 24 hours ambulatory BP monitoring system. Because in this what happens is the patient is connected with a ABPM, and patients can be monitored for 24 hours. The blood pressure monitoring can be measured at the awake time as well as the sleeping time, that is the resting time. At the same time, in this we also measure not only the average of the blood pressure, systolic and diastolic, we also measure what is called as in the night whether they are the non-dippers. That means to say that when we are sleeping in the night, when you are taking rest, the blood pressure should fall. Suppose there are some people whose blood pressure doesn't fall, they are at higher risk for cardiovascular mortality. At the same time, we also have one more way of analyzing the ABPM. That means when your early morning surge of catecholamines will cause a systolic pressure to be high when we are measuring 24 hours. That means somewhere between 4 to 5 a.m., if our systolic pressure is remaining high, that means we are at very high risk for stroke and cardiovascular events, because that is the time when the platelet adhesions occurs. So early morning, we get most of the vascular events, including the stroke and myocardial infarction, is common because these people who have a what is called as the early morning surge of blood pressure, systolic blood pressure, which causes for them to be at higher risk of the stroke. There are some indications like borderline or white coat hypertension and isolated systolic hypertension. These are the conditions where we ask them to undergo a ABPM. Now coming to the recommendations, when we go for ESH recommendations, if awake should be more than 140/90 is considered as abnormal, but asleep 125 to 65 is considered as abnormal. Now there are some differences and similarities between the guidelines what we are following. There are three guidelines which we are following. One is JNC 8, which is released in 2014. Then European Society guidelines, which are released in 2013, and the American Society of Hypertension, which released in 2014. If you see that three guidelines, what we are finding is that 140/90, this is the JNC 8 which we are following now, because anything above 140/90, below 60 years of age is considered as hypertension, and 150/90 for above age of 60 years. So when compared to the ASH is almost, they take as 80 years, but this is 60 years. That is one difference. At the same time, when we are managing, the beta blocker is initially taken as no beta blocker is used as first line of therapy in JNC 8 and ASH, but in European Society it is accepted. Now coming to the Indian hypertension guidelines, this we should see and highlight on that is that this is the most attractive and most complete guidelines which we have at present, because I used to follow what is called as British Heart Society BHS guidelines, and this is almost looks like BHS guidelines, but there is some improvement in that. If you look at this, younger and older, that means somebody below 55 is treated in different way when compared to older, that is above 55. The first step is that first drug what we try to use is A. A is either AC inhibitor or ARB or B. B is beta blocker. So we have included beta blocker as can be used as the first line of drug. But the beta blocker what we are recommending is a nebivolol. That I will come later. If it is older, that means if he is more than 55 years of age, then a calcium channel blocker, C is calcium channel blocker, or D is thiazide diuretic. Now when this pressure doesn't get controlled, then we go for step 2, where A or B can be combined with C or D. And the step 3 is A, B, C or D. So the third and the fourth step is where there is a resistant hypertension, we try to add spironolactone. So this is the Indian hypertension guidelines, which was released by JAMA in 2013. Now we have fixed combinations also, we are using it as, because you know that hypertension sometimes have a cluster of other risk factors associated with that, we can definitely go for a poly pills. Now coming to the beta blocker, as you know that beta blocker is not accepted as the first line of drug by by the American Society as well as JNC 8, because of these two studies which were way back it was published, and both the studies were compared with the atenolol, which is the oldest beta blocker. So it is a lot of atenolol bashing. Therefore these two studies showed that atenolol versus atenolol, losartan and amlodipine fared better, therefore they didn't use it. However, we have a newer beta blocker called nebivolol, which is also having a third generation vasodilating beta blockade effect. Therefore it can be used as first line of drug in our Indian patients. Therefore it has been included in Indian guidelines. Now coming to the calcium channel blocker classification, this is too basic, I'll go further. But today I want to highlight on one newer drug which has come into our practice, which is being used slowly, is the benidipine, because this is the only one which is the longest acting calcium channel blocker present in our clinical practice. As you know, the calcium channel blocker, there are 6 types of calcium channel blockers in humans, out of which L and T are the target for treatment. Benidipine is the only available drug which acts on T, that is a transient calcium channel blocker channels. So because of that, they are confined to the renal as well as the juxtamedullary efferent and efferent arterioles, there they are present. Therefore they have more effect on the cardiorenal events. So therefore if you look at this way, L type, N type and T type, you can see that the T type has the highest vasodilatation and less glomerular pressure and less aldosterone secretion when compared to the L and N type. Look at the present calcium channel blocker which we have, the nifedipine has got only L type, amlodipine has got L type, cilnidipine has got L and N type, and benidipine is the only drug which has got all the 3 like L type, N type and T type. Therefore I think it's a very novel calcium channel blocker, because it has got a almost 19 times potent than amlodipine for vascular selectivity. And therefore because of that, it is almost considered as cardio-reno-neuroprotective. By one of the studies, it showed that the incidence of edema which we come across with calcium channel blocker is very negligible, just 0.3%. Therefore I feel that we should start using it in a little bigger way to find out how our patients will do. It's available as 4 and 8 milligram, and it is the only calcium channel blocker we can say it is long acting and truly once daily, because it's highly protein bound. So now coming to the 3 trials, very short briefly I like to tell that these 3 trials are the latest trials, where is some confusion is there how to come to the conclusion. The 3 trials are SPRINT, HOPE 3 and ACCORD B. The SPRINT trial was just released in November in 2015 in EJM. The idea of this trial is that they want to know at what level we should bring the blood pressure down. Like our target should it be 120 millimeter or should it be 140 millimeter? I know in our clinical practice it's very difficult to get a blood pressure below 120. So this trial was directed towards that. So they want to know whether 120 below is better or 140 below is better. For that purpose this trial was done And but unfortunately, this is the highlight of this trial, is that the two important side effects of this trial which showed is hypotension and acute kidney injury is very pronounced in those patients whom you want to bring the BP below 120, 80. The p values are very significant. But they concluded that if you bring the blood pressure down to 120 and below, they have lesser cardiovascular, the events are less, the deaths are less. But we can take the potential of harm is less compared to the this one. So they concluded that we should target the blood pressure to 120, below 120. However, the next trial which came is the HOPE-3 trial, which is done by Dr. Salim Yusuf, who is a very well-known Indian who is practicing in Canada, and he is involved in a lot of studies starting from the HOPE trial. They did one trial wherein which they want to know how low we can go for a blood pressure measurement. So they included the patients who have normal blood pressure and started antihypertensives in them and find out whether that is going to reduce the cardiovascular events. So they use a hydrocortisone, hydrochlorothiazide as well as candacertan combination. But they found that in this trial, when they have compared, there is no difference between placebo and those on antihypertensive drug. Therefore, they said there is no significant difference. Therefore, they said that lower is better hypothesis is not accepted. So therefore, that is the conclusion. What they said is 140/90, whatever we are targeting is as good as in our clinical practice, but only thing is that if that any patient has got a proteinuria significant, please bring down the systolic pressure to 130 and below. Otherwise, if they don't have proteinuria, even in non-diabetic or diabetic, it can be targeted below 140 rather than 120. This is the conclusion of this trial. And the ACCORD BP trial is another trial which also try to compare in diabetic less than 140, less than 120, and they also concluded the similar way that there is no difference between the thing. Therefore, we can as well take it 140/90 for the except for proteinuria. Therefore, after that the goal for blood pressure goal has been changed, and everybody, most of the three societies have accepted that 140/90 below should be the target. And in those patients whom we are having a CKD or a proteinuria, we can have a lower target. Now, coming to that, whether morning or evening, it has also been clearly shown that when we are giving a single antihypertensive, it is better to give in the evening hours, because that will also look after the early morning surge. So, in conclusion, I like to conclude that hypertension is really a problem which is facing our country, but it is under treated, as well as the prevalence is not very well taken. So we have to have methodology to measure the patients accurately, and we can use a ambulatory BP monitoring apparatus for that purpose. Our aim should not be lower is the better. Ideally, we should treat below 140. That should be the systolic blood pressure target. And the choice of drugs, again, the newer drugs have come. Beta blocker can be used as first line of drug, and benedipine is a newer drug which has come to our armamentarium. And the choice of drug is again individualized. And it is high time that we have our own cardiovascular outcome trials. Thank you so much.
Thank you very much, sir, for such a knowledgeable session.